a very good grasp of of how inhalability works and why it's really important for your COPD patients. The following are my disclosures. I do research work, CME, and Honoraria, and the following companies. Now, if there is a key parameter in getting the right inhaler, you should really look into peak inspiratory flow rate. What is peak inspiratory flow rate? It is the measure of a patient's inspiratory effort and is the maximal flow generated during a forced inspiratory maneuver. So the faster the inspiratory flow, the higher inspiratory flow rate, the more choices you have with your inhaler. Because for certain inhalers, a minimum peak inspiratory flow rate is required just to overcome the device's internal resistance. And even for these inhalers with very low internal resistance, your COPD patient may actually struggle to generate a sufficient respiratory effort due to the underlying pathophysiology of the disease. And a patient's peak inspiratory flow rate, or your PIFR, can therefore affect the ability of certain inhalers to effectively deliver the drug that is recommended for your patient to the lower airways where it should work. Now, this peak inspiratory flow rate is such a factor that links COPD disease and its burden for the longest time. The inhaler that you prescribe to your COPD patient is actually necessitates that your patient is able to inspire the inhaler properly. And for us to say that most of your patients will benefit from your inhaler, you have to have what we call the optimal peak inspiratory flow rate. And this is generally considered to be greater or more than 60 liters per minute. Anything lower than 60 liters per minute is considered suboptimal. This is a study published in 2020 from the European Journal of Pharmaceutical Sciences. And it tells us that suboptimal peak inspiratory flow rate is present in most of your COPD patients. In fact, for the female gender, where they have less lung volume, more than 50% will actually present with suboptimal peak inspiratory flow rate. That's why you have to be very wary when you prescribe your inhalers to your female COPD patients. You check, are they able to generate enough peak inspiratory flow to be able to get the benefit from the inhaler that you're giving them? For males, around 35% will actually have suboptimal peak inspiratory flow rate. Now, this factor is actually linked to COPD readmissions. It makes sense because a patient who you send home from a COPD exacerbation will have less inspiratory flow rate due to the exacerbation. And if these patients would have lower inspiratory flow rates from normal, they might not be able to get the benefit from their usual inhalers. That's why in some centers, when they send home their COPD exa, they send them home on nebulized medications because they cannot inhale their usual inhalers because of low peak inspiratory flow rates. And this factor is actually linked to higher rates of 90 days COPD rehospitalization and a shorter time to all-cause readmission for any cause. And if you're going to look at your COPD patients who are in exacerbation and who are admitted, more than a third of your patients will have suboptimal peak inspiratory flow rates. That's why in exacerbations, you rarely see doctors prescribing inhalers. We prescribe these inhalers when they are getting well, when they are in our outpatient, because you would expect that these patients would have suboptimal peak inspiratory flow rates. Now, when you think about an inhaler that should be prescribed to your COPD patient, the first thing that you need to assess is, can your patient inhale the medication? That's the biggest difference between inhaled medication and oral medication. If you have an oral medication and your patient is able to take it orally, then you are assured that the pharmacologic effect of that medication will already work. But with inhaled medications, you have the right medication, the patient does not take it properly or takes it properly but it doesn't reach the target area, then you can be assured that this patient will not likely benefit from your inhaled medication. And choosing an appropriate inhaler device for the treatment of adults, both with asthma or COPD, is critical to your success. How can you assess? Ideally, you'll have what we call an inject device, a device that measures the inspiratory flow rate and will actually tell you which inhaler is best for your patient. But since not all of us will have access to this device, you can ask your patient to do two maneuvers. The first maneuver is the slow and steady maneuver, where the patient can take a slow, steady breath in over 3 to 5 seconds. And it goes something like this. If your patient can do that, after assessing, can perform slow and steady on the left side, you can consider a meter dose inhaler, a soft mist inhaler, or a breath actuated inhaler. The other thing that you ask your patient to do is a quick and deep breath. A quick and deep breath will make this patient having good peak inspiratory flow rates. And it goes something like this. So you ask the patient to take a quick deep breath in within 2 to 3 seconds. It's fast and furious. And if the patient can do that, then can perform the quick and deep, you consider your dry powder inhalers. I've seen patients who can empty the capsule of a dry powder inhaler and yet does not benefit from the medication. Because the way they do it is that they put the capsule and they put it in their mouth and they do like this. And in 3 or 4, 5 short breaths, they're able to empty the capsule, and yet 90% of the medication is stuck in their oropharynx, and it will not work. The medication needs to be in the lungs for that to work against COPD. Many of these standards inhalers are inefficient at delivering to the small airways where the receptors are and where your medication should be. And if the medication does not reach your small airways, this would actually lead to poor COPD control. For the medication to reach, it has to be of a certain size. And this is what we call the fine particle fraction. For this medication to work, aside from being of a certain size, it has to move in very gradually, not so fast, or otherwise, even though it's of the right size, it will just impact on the areas where it should not be. And the different drug particle sizes really affect lung deposition. So for us to have very good deposition, so your leftmost is 1.5 micrometers, in the middle is 3, and on the right is 6 micrometers. You can see that very good deposition is achieved between 1.5 to 3 micrometers. And in fact, the fine particle fraction should be between 1 to 5 micrometers. Why? Because anything less than 1 micrometer in size will just go in and will go out on the next breath. If that medication is more than 5 micrometer in size, then with the inhalation of the medication, it was just lodged in your oropharynx. The fine particle fraction for your dry powder inhaler is as low as 6.5% to 35%. Whereas for meter dose inhalers, it could range from 26 to 43%. But for soft mist inhaler, this can give you a fine particle fraction greater than 75%. And this is the reason, if you can go back 10, 15 years ago, where Spiriva is found in the 18 microgram capsule. And now, with the Respimat soft mist inhaler, it can be given as low as 5 microgram per inhalation, per dose, and yet would have the same effect. So the other is a dry powder inhaler, the other is a soft mist inhaler, and the difference is less than one third of the medication is now being given and having the same effect. With your soft mist inhaler in the Respimat, you can achieve as high as 53% total lung deposition because of its reduced aerosol velocity, its long aerosol duration, a high fine particle fraction, giving you deep lung delivery. The Respimat soft mist inhaler delivers the drug to where it is needed the most, in your lower airways, in your small airways, and the delivery is such that 56% are delivered to your peripheral airways where the problem of COPD exists. The soft mist inhalers, compared with your metered dose inhaler, even at different levels of inspiratory flow rate. So if you're going to compare, we have 4 lungs here. The one on the upper left is using fluticasone formoterol metered dose inhaler with a 30-liter flow rate. On the upper right, your budesonide formoterol metered dose inhaler at 60 liters per minute. On the lower left, your fluticasone bilateral dry powder inhaler. And you can see the very low deposition rate, central airway, peripheral airways, 18%. And lastly, on your lower right is your Spiriva Respimat, the soft mist inhaler, delivers a combined 56% deposition on your central airway and your peripheral airway. For your Respimat, it's easy to use. Day-to-day use, you only need to remember the TOP procedure or your top procedure. First is you turn the clear base following the arrows on the label until you hear a click. You open the cap, push it around until it clicks in the open position, and breathe out slowly and fully. Close lips around the mouthpiece without covering the air vents. And while taking a slow, deep breath, press the dose release button. Keep breathing in slowly and hold your breath for 10 seconds or as long as is comfortable. You breathe out slowly and you replace the cup. With the Respimat soft mist inhaler, patients only need to breathe in normally. For daily use, just remember, turn, open, and press. Now we've talked about peak inspiratory flow rate. This is a very important patient factor in determining what inhaler your patient will receive. But there are other device characteristics and patient factors that are important considerations in inhaler choice. For the device, you need to talk about aerosol velocity, aerosol duration, the particle size, and the internal device resistance. And for your patients, you need to look at inhaler technique also, and eventually adherence. A medication that they do not use will not make them better. Effective treatment of COPD requires that the inhaled drug reaches the peripheral areas of the lungs to achieve the desired therapeutic effect. And that, doctors, I think, is your peak inspiratory flow and how it relates to your inhaler selection. Back to you, Dr. de los Reyes.